I'm going to go ahead and get started. I know we may have a few more people jump on, and that is fine. Welcome again. We're having our September Tobacco Free Tuesdays webinar. We have it on the third Tuesday of every month. And we're excited to have some wonderful speakers join us to really touch base on what we as the tobacco use control community need to focus on in our local communities and statewide. So this is a wonderful webinar. Please share your link. Please share when you get the next registration information, sign up and pass it along. I do want to welcome the few of the panelists, the tobacco use control team that is on the screen today. We are in webinar mode, the Zoom webinar feature, which is new to us. So we're not able to see your faces, and I miss that actually a lot. So, but this will provide things easier for us to make registration and to share things and to send reminders to the group. So we're testing this out. Please let us know whether you prefer this webinar feature or the meeting feature where we can see your faces. But we're doing this today. We have Nicole Mahan on the phone, and she's with the Eastern Region, the Portsmouth Health District, and she will be our chat moderator and the Q&A moderator. We have Sarah Burkhead from the Richmond Health District. She's the Central Regional Coordinator, and she will provide our technical support, our webinar support. And I rely on her a lot for this support. I rely on all of the team because we really have a great team. And we have Carrie Cannon here, our newest regional coordinator from Fairfax Health District. She's the North Regional Coordinator, and she is also support for us here today too. So again, we will be monitoring the chat and the Q&A, and if you do have questions, try to put them in the Q&A feature because this is a new feature for the webinar Zoom portion of this. So put them in the Q&A. Nicole will be monitoring the chat, so you can definitely chat with us as well. So we will go ahead and get started. As you know, if you've been joining us each month for the past 4 months, we always do a few what's the tea questions so that we know more about who is on the call and what you know about tobacco control. And in this instance, what you know about behavioral health. So the very first question, I hope you're all seeing it on your screen, is which of these areas best to match your workplace? So we want to know where you're coming from. So please take a minute and check one of those off. Just a couple more seconds to put that answer in there. And I know question 2 pops up for me as well, but I think we're just focusing on the first question right now. Okay, let's see where everyone is from. Sarah, are you seeing where I am not showing where everybody is from yet?
So this is one of our first technical things with the webinar versus our last view. I'm not sure. Last time it brought up all 3 separately. So I'm going to end the poll and maybe we can just talk about them. Yeah.
That's perfect. Yes, I'm seeing where everyone is from, and the majority, well, it's very close. We have a whole range of places. 22% behavioral health, mental health services, 22% substance use prevention, and 22% health system. So perfect. That's wonderful. Thank you, Sarah. Now, did we get answers for the next set of questions, or have people voted on that? We're learning. This is a learning process, so bear with us.
Do you want to just talk about number 2 and number 3, Tina?
I will do that. What we were asking people, the number 2 questions, individuals with behavioral health conditions make up this percentage of the US population. And we are given the percentages 5%, 10%, 25%, or 40%. And the correct answer, and I know Tamana is going to talk about this too, but the correct answer is 25%. So 25% of individuals with behavioral health conditions make up 25% of the US population. But the next question was, individuals with behavioral health conditions consume this percent of all cigarettes in the United States. And we're given those choices as well, 5%, 10%, 25%, and 40%. And the answer was 40%. So whereas individuals with behavioral health conditions only make up 25% of the population, they consume 40% of all the cigarettes in the United States. So that's pretty telling. And that's the reason that we have our speakers today. And we're so glad to have Tamana and Samara with us, joining us to really make sure that our focus is on this population because it makes up such a huge population with us. So I do want to take this time now to introduce Tamana Patel. Tamana is the Director of Practice Improvement at the National Council for Behavioral Health. She serves as a program director on a variety of national health equity initiatives focused on the intersection of public health and behavioral health, including the National Behavioral Health Network for Tobacco and Cancer Control. Tamana's portfolio of work has risen to providing expertise to federal and statewide funders and initiatives by translating key insights and learnings from the field to inform policy, program, and research. But Tamana brings over 13 years of experience to her work, and we are so excited to have you today with us today, and we look forward to your presentation. Thank you, and I'm going to turn it over now to you, Tamana.
Great. Can everyone hear me?
Yes.
Okay, great. Well, good morning, everyone, and thank you so much for having me and my colleague here today, Samara Tamid. We're going to provide you with a lot of information over the next 30 to 40 minutes, and I'm going to try my best to not overwhelm you. So as questions come up, please feel free to jot them down. I promise I will leave plenty of time for any discussion or Q&A that you all would like to have. So again, I'm joined by my colleague, Samara Tamid. She's going to be dropping a lot of things in the chat, resources, links, and things like that as I call them out. And then I'm Tamana Patel. I'm the Director of Practice Improvement here at the National Council for Mental Wellbeing. We did change our name back in May, so many of you might know us as the National Council for Behavioral Health. However, we have rebranded ourselves and we are now the National Council for Mental Wellbeing. And I lead our National Behavioral Health Network for Tobacco and Cancer Control. So a little bit about the National Council for Mental Wellbeing. We are a membership organization that drives policy and social change on behalf of nearly 3,500 mental health and substance use treatment organizations that serve more than 10 million children, adults, and families, right? We advocate for policies to ensure equitable access, high quality services, as well as building the capacity of mental health and substance use treatment organizations. You all also might be very familiar with us through our mental health first aid program, right? And through that program, we've trained more than 2.5 million people in the US to identify, understand, and respond to signs and symptoms of mental health and substance use challenges. So I mentioned I'm the director of the National Behavioral Health Network for Tobacco and Cancer Control. It's a 5-year program operated by the National Council. I think this is a little bit misleading, actually, the 5 years, because we're actually in our second cycle of 5-year opportunity we have with the CDC. And we do this in partnership with the Smoking Cessation Leadership Center, Behavioral Health and Wellness Program out of Colorado, as well as the Michigan Public Health Institute. We are jointly funded by the CDC's Office of Smoking and Health and the Division of Cancer Prevention and Control. And we focus really on providing our members with resources to support efforts in addressing any cancer, tobacco-related disparities among individuals with mental health and substance use challenges. You see our website in the top right-hand corner, bhthenchange.org. If you're not currently a member, I strongly encourage each of you to sign up. It is free, and you will gain access to many of our resources, archived webinars, toolkits, and so on. In addition, our core activities as part of the network is we have this member exclusive listserv. We send out monthly newsletters, monthly e-digest. We offer a lot of webinars, trainings. We participate in the state strategy summits, and we operate some communities of practice, which is a 6-month practice change intensive. So we do a little bit of everything, and we're here to support you all in anything that you all need. I do want to spend a quick moment about language and terminology. Here at the National Council for Mental Wellbeing, we're really committed to changing the conversation around mental well-being to be more inclusive of those with mental health and substance use challenges. Each of us contribute to inclusion. We all have a role to play, right? And our culture is the result of our mission to ensure that everyone has access to comprehensive, high quality, affordable mental health treatment when they need it. So our inclusive culture really inspires us to connect, grow, respect others and their cultures. And so as such, we're really defining some of these common terms and language that you might hear throughout today's presentation. So I want to begin by framing this work around health disparities and equity, right? And I'm sure this is not unfamiliar to any of you. But I really want to begin with the understanding of those root causes for and the determinants of health, so we are not left speculating what are the tobacco determinants among individuals with mental health and substance use challenges, and how each of these impact access to care and result in tobacco use, right? So why do individuals smoke, right? Why do we see this disparity? Well, we know that our health and our health outcomes is determined by other factors, in addition to our own behaviors, which is where traditional programming is often designed for, right? But these other factors, often outside of our locus of control, so the environment, access to care, community, and societal factors. Oops, I did not, my mouse is very sensitive, I'm sorry. So without considering these other factors you see here, right, we're left somewhat lacking in our approach to address disparities. So we have to consider from a systems perspective, what is it that puts people at risk? And how can we craft interventions in response to those drivers? And so I'm hoping by the end of the presentation today, we can all leave here with an understanding that the environmental approaches that will impact tobacco use, those clinical care and provider approaches, the client level approaches, really looking at the cause and different ways to address it at multiple levels, right? And then what does it mean for the future? So the overall cigarette smoking, the overall rate of cigarette smoking among adults has been falling steadily, right, over the last couple decades. But people with mental health and substance use challenges have been neglected. We already discussed that 1 in 4 individuals in this country experience a mental health or substance use challenge, but they consume 40% of all commercial cigarettes, right? This can be attributed to the predatory practices of the tobacco industry. Targeted advertisements, providing free or cheap cigarettes to psychiatric clinics, the intentional blocking of smoke-free policies in facilities, as well as funding research that perpetuates this normalized myth that cessation would just be too stressful and negatively impact overall behavioral health outcomes, right? And we see decades later, right? Vaping companies are taking a page out of Big Tobacco's playbook, and with the rise of the vaping epidemic, especially among youth. So it's important that we begin with, why are people smoking? right? What we know are, what you see here is listed as some of the reasons we know why people start smoking. Yes, the targeted predatory marketing, right? Limited access to high quality care, there's delays in care, lower quality of care, but what we don't often consider is the high rate of ACEs and trauma, ACEs being adverse childhood experiences, right? And I really want to highlight in a minute the connection between trauma and smoking initiation, because we don't often consider trauma in our tobacco prevention and cessation efforts, yet there is a strong connection between these two. So let's look at some of our prevalence rates, right, and our prevalence data. If we explore the prevalence of trauma in behavioral health treatment settings, you know that research sometimes uses ACEs or trauma interchangeably. I will make it clear which one I'm referring to if there is a call for distinction. But what we know is that the majority of patients in treatment settings report some form of trauma history, right? 76% of adults with history of trauma experience at least one psychiatric disorder in their lifetime. We know that many adults and children in patient settings report a trauma history. We know that public mental health clients are exposed to trauma, and more than 70% of substance use treatment reported a history of trauma. Oftentimes, we have conversations around tobacco and tobacco control, right? We don't ground in trauma. And so it's really about reframing the conversation from what is wrong with you to what has happened to you, right? We know that there are high rates of trauma in behavioral health settings, and we know this, right? Because as with alcohol use and other ACEs, adverse childhood experiences, ACEs increases the likelihood of early smoking initiation, and the experiencing of ACEs has a dose-response relationship with tobacco use, right? So I say early smoking initiation, I mean prior to the age of 18, right? And so what you see here is 21% of those with 4 or more ACEs report early initiation of smoking, compared to only 5.5% with no ACEs present. We also know that smoking or tobacco use is addictive, right? That it results in nicotine addiction. And so beyond correlations with first use, we also see a similar prevalence between ACEs and adult current smoking prevalence, because once smoking has been initiated, your risk of continuing to smoke is heightened, which is what we see here in the comparison, right? And ACEs not only leads to early smoking initiation, but continued smoking. So that's through adult use, strong association to heavy smoking, which is the amount of use, and then the longer duration of use, and then the risk of COPD and other chronic conditions, right? So as we're planning for designing, programming, even just developing our approaches around tobacco cessation and control in behavioral health settings, we really have to find ways to be trauma informed and integrate that into our work, right? What you see here is the prevalence of daily and non-daily smoking by the ACE study groups. The two most common and persistent resultant adult health condition from ACEs or trauma exposure, right? That CDC continues to publish and validate time and time again. In ACEs studies are that adult depression and adult tobacco use with the resultant COPD, right? So the takeaway here too is that the two most significant health conditions from ACEs is depression and tobacco use. So let's back it up a second, right? Because I said earlier that tobacco smoking rates have decreased, right, in the past couple decades. We know in the general population where we've seen those significant rates of decreasing tobacco use, we haven't seen that same rate in the behavioral health population. And that is largely due to all the efforts and strategies and approaches that went into curbing that general use. So increasing access, education, changing the social norms, right? Policies and funding, all of these things had to occur to really curb tobacco use among the general population, right? But these things have been unequally applied to or provided to behavioral health populations. We know since the first 1964 Surgeon General's report, which examined the health consequences of smoking, it changed Americans' perceptions and attitudes towards tobacco use, right? And that was because they were able to link it to chronic bronchitis and cancer, right? What we see and continue to see more than 50 years later are these more extensive findings that link tobacco use to many types of cancers and chronic conditions, other than those directly related to the lung, right? So screening for tobacco use among individuals with behavioral health conditions takes a back seat to their mental illness, right? And so because of that, we're seeing this delayed screening compared to the general population, often leading to enhanced chronic conditions. The other thing I want to highlight here too, and as the research shows, the other important thing to consider here is that the more adversities an individual faces, the more likely they are to start smoking and the less likely they are to quit. So in addition to the core exposure to trauma and trauma history, there's been research around linkages to tobacco use and smoking around these 6 socioeconomic health-related disadvantages, which you see here, right? Unemployment, poverty, low education, disability, serious psychological distress, and heavy drinking. 14% without any of these disadvantages smoked. But with each added disadvantage, smoking rates increased, rising to about 58% among individuals with all 6 disadvantages. If we were to look at a number of the other priority populations that also see disparate rates of tobacco use, right, such as race and ethnicity, education levels, socioeconomic status, health insurance status, disability and ability, sexual orientation, and of course, behavioral health populations, they're all intersectional, right? And so, for example, between 70 to 80% of individuals who are homeless use tobacco. Close to half have a diagnosable mental health or substance use challenge, right? So I bring all this up because the key here is disadvantage. Disadvantage is the common denominator for smoking in the US today. And if you're facing increasing disadvantages in your life, you're more likely to start smoking and less likely to quit. And so some of you might have seen this before. All of this really leads to a very important statement that people with mental illness die on average 5 to 25 years earlier than those without. But it's really important that we finish that sentence, because why? What does that due to? It's due to complications from smoking-related illnesses, right? And this leaves many to believe that individuals with behavioral health conditions, morbidity and mortality is actually due to their condition rather than tobacco use and the interaction with their diagnosis, right? And so to look closely at the data and understand what the disparity looks like, it's pretty significant, right? You all were spot on earlier about 1 in 4 have some form of mental illness or substance use challenge, but they consume 40% of all commercial cigarettes. And so I want to take us through briefly what the disparity actually looks like before we talk about what are the strategies, right? I mentioned the good news is that the overall trend in tobacco use is down, right? This is really owing to states and others like yourselves, some of you on the line today, working really hard in tobacco control over the last couple decades, right? But as we see, adults with behavioral health conditions, that is mental health challenges and substance use challenges, you're smoking at a prevalence rate almost double the general population, right? What you see and what you're going to continue to see in the next couple slides is that the blue line are those with behavioral health conditions. The orange line is those without a behavioral health condition, right? If we look at any mental illness in the past year, so only looking at mental health, not substance use, we see a similar trend in the prevalence of smoking in the past year, right? 27.2% compared to 15.8% among the general population. If we look at serious mental illness, we see a much higher rate. That's about 33% among those with serious mental illness compared to those in the general population at 17.3%. If we look at past year substance use disorder, right, what we see here is much higher in the differential with past year use, right, 42% compared to 16%. So I just offered a quick high-level overview of the data trends to really show you where the disparity is, right? And that really is the point. And now that we've looked at the disparities, we have to look at individuals with behavioral health conditions. We turn our attention, right, and see where is the disparity, where's the differential in access and quality of care that really impacts rates of tobacco use and cessation. So here you see what probably a lot of you are familiar with, right? These are evidence-based practices that work to reduce tobacco use rates and how they are and are not applied in mental health facilities and substance use treatment facilities, right? We have seen some improvement in tobacco screening, right? And we see some low rates in offering tobacco cessation services, interventions, and nicotine replacement therapy at these facilities. We look at smoke-free grounds and facilities, we're doing a little better, right? A little more than half for mental health facilities, about 34% for substance use treatment facilities, but we still have a ways to go, right? Because we know that there is a strong correlation between environmental approaches and tobacco use rates, right? And so I present this information to you in this way to really show you the opportunity, right? There is an opportunity here for public health and behavioral health to come together and work to really maximize these evidence-based practices, right? Because behavioral health providers are often tasked with addressing the primary concern, diagnosis or symptomology, right? But addressing the issue more holistically by really grounding in the cause of morbidity and mortality. I do want to also note here under nicotine replacement, individuals offered NRT supports, they do have a higher success rate at cessation, right? And so that is one row I would call your attention to and think about what are the opportunities to really leverage that. We still have room to grow in that. So it's worth noting that individuals with mental health illness, mental health challenges and substance use challenges, they want to quit. They're actually more than 2 times likely to quit with the help of cessation medication and counseling services. But also they can successfully quit, and cessation can actually enhance long-term recovery for persons with a substance use disorder. Here you see some more prevalence data. Lifetime smoking rates are even higher in individuals who are diagnosed with major depression disorder, bipolar disorder, or schizophrenia and other psychotic disorders. It's worth noting that individuals with depression who smoke are more likely to relapse, and individuals with substance use disorder more heavily nicotine dependent. Here, I would like to note too, there's about an estimated 200,000 adults who have a mental health disorder and comorbid substance use disorder. And they die from tobacco-related causes each year, right? And this is due to the higher smoking prevalence and the disparity in access to prevention and treatment. I mentioned earlier, so I do want to quickly touch on what's happening with e-cigarettes and electronic nicotine-free devices. Individuals with behavioral health conditions are also significantly vulnerable group for high e-cigarette use, right? Individuals living with depression and anxiety are twice as likely to have tried e-cigarettes and 3 times as likely to be users of battery-powered ends. So individuals with mental illness often combine e-cigarettes with concurrent use of the traditional combustible cigarettes, and it makes them more at risk for nicotine addiction. and susceptible to the effects of traditional tobacco. Okay. If we were to look at ENDS use, individuals with any mental health condition were almost twice as likely to have lifetime use of ENDS. Individuals with any mental health condition were 2.3 times as likely to have current use of ENDS. Some of the specific mental health conditions most likely to experience disproportionately high rates of ENDS include bipolar disorder, anxiety disorder, and depression, right? So I'm hoping all of this has led me to summarizing here, why is it that we should integrate tobacco prevention, cessation, and treatment into our practice, right? In a snapshot from everything I have said up until this point, tobacco use kills half of our patients. It limits full recovery, particularly among those with substance use disorder, even though tobacco use disorder is in the DSM, but it's the only substance use disorder that is not routinely diagnosed and treated for in mental health settings, right? And tobacco use has a negative impact on treatment, right? Stopping smoking doesn't have a negative impact on treatment for other addictions. This is a myth, right? It can increase long-term abstinence of drug and alcohol use by as much as 25%. So what do we do about this, right? And this goes back to that other slide I showed you of those evidence-based practices that are and are not applied in mental health or substance use treatment facilities. And so it leads us to these recommendations, right? We know adopting tobacco-free facilities and grounds policies, really applying that environmental approach is highly effective, right? We know integrating tobacco treatment into behavioral health facilities, really increasing that quality of care. Utilizing Quitline, right? That can help with the access issue, as well as engaging peer models. We know that this really works, right? And thinking beyond cessation to recovery. And so I'm going to go into a few of these real quick, just so you can understand how we view these strategies, right? So adopting tobacco-free grounds policy, right? And we do a lot of work with states and other facilities on taking facilities tobacco-free, right? And so what does that actually mean in terms of adopting tobacco-free grounds and policies? And how do we get there, right? These are 10 simple steps in approaching a tobacco-free policy within your facility. Of course, we have more information. It's 10 clear, simple steps, but how you achieve each step, we definitely go more into in other trainings and webinars, and we have additional resources that somewhere might be dropping into the chat right now. This is something we can also assist with, right? Is how do you adopt tobacco-free facilities and grounds policies? How do we get there? And the 10 steps that lead us to that accomplishment. Integrating tobacco cessation treatment, right? So more than 3 out of 5 adults who have ever smoked cigarettes have quit, right? Although a majority of the cigarette smokers make a quit attempt each year, less than 1/3 cessation medications that are approved by the FDA or behavioral counseling to support to quit, right? Cessation medications approved by FDA and counseling really does increase that successful quitting, that likelihood of successfully quitting long term, right? And the other point that I want to make here is that look at quit attempts, right? Not everyone is successful after the first attempt, right? And we can't hold everyone to that standard. It's about that it might be a combination of things, and they might engage to quit several times. And so really understanding that piece of the data too, what are the quit attempts as well, and how can we best put together the most holistic and comprehensive strategy to really support these individuals in that long-term recovery, right? and cessation. The other thing I want to note here is Quitlines, right? How can we best leverage the Quitlines, whether you are or are not right now, right? The Quitlines really do offer a lot of that additional support and increase that access, especially for any mental health or substance use treatment facility that might feel tapped out, right? And that they don't really have the capacity to address tobacco cessation. This is a great resource, right? Because they provide free or subsidized cessation coaching and medications. It's done telephonically, or I believe they've expanded to web and some other methods as well. They are funded by a variety of different mechanisms. And I do want to note here, as my colleague Samara had mentioned, I think she might be dropping an article into the chat as well, that are one of our partners at Behavioral Health Wellness Program up in Colorado, had put out an article earlier this year, and it looks like about 50%, or a little bit more than half, of Quitline callers report a behavioral health condition, right? I think this is an opportunity here to, if you haven't already, start beginning conversations with your Quitline vendor, right? Really looking at what is the data that they're collecting on the callers, right? And then how can you best support and streamline, especially if you are seeing a high rate of callers experiencing a behavioral health condition, right? Peer recovery. Peer support, I'm not sure how many of you all are familiar with this, but peer support is the process of giving and receiving non-professional, non-clinical assistance from individuals with similar conditions or circumstances, right? To really achieve that long-term recovery from psychiatric, alcohol, or other drug-related problems. This is a highly effective model. We know works. We know is successful. The benefits is really that informational support, emotional support, and really helping link individuals to the available resources that are out there, right? And there's some examples of where peer support specialists, peer recovery specialists, some states, the terminology is a little bit different, but they're interchangeable, where this position sits, and there's some examples here as well, right? And they're really valuable between that period of when they enter recovery, between recovery and relapse. I mentioned that sometimes it takes multiple quit attempts, right? We know that there's a lot of stressors out there, economic distress, stress in general, the lack of social support, social risk factors, and motivation to quit, right? When those things feel like they're crumbling down on somebody, their risk of relapsing and use tobacco to cope increases, right? And so peer recovery, peer support specialists, and other additional services and resources can really help that recovery, that long-term recovery, right? Because I mentioned before, sometimes it might take a couple quit attempts, right, to get it right. But recovery is possible. We've included SAMHSA's working definition of recovery and the principles that are associated with recovery-oriented care that you see here. Again, this is an area that we go deeper into in additional webinars and trainings. So I'm really just giving you all the high-level information about it. The other thing I want to call your attention to is something that we have put out recently. Samara will probably be dropping it into the chat that you all might find of use as well. We developed a toolkit to best address disparities related to mental health and substance use disorder, right? There's this implementation toolkit. Yes, it is technically written for state public health and tobacco control, but it's actually both a guide and a call to action to really strengthen focus in identifying and addressing tobacco-related health disparities among individuals with health and substance use disorders. So there's actually components in there that are speaking directly to providers and facilities as well. And so we believe that this toolkit can be used by a multitude of sectors and stakeholders that really are working together to improve health and reduce these tobacco-related disparities. The purpose of this toolkit, it was actually developed by a team of multidisciplinary experts, right? It includes a lot of practical examples, some solutions, resources, and tools, right? All of these coming together in a toolkit to really help close the disparity gap, right? Drive implementation activities and really support individual community using this trauma-informed, resiliency-oriented services to promote that long-term recovery. It does address these three critical questions. So how can we implement tobacco-free policy in treatment settings? How can we increase tobacco use and dependence screening in these settings? How can we support tobacco cessation treatment assistance clients in these settings, right? So some of those things that I touched on earlier today, you're going to find a lot of tools, resources, and practical solutions to start addressing those within your own facilities in this toolkit. This toolkit also includes actually where strategies work. So we've really tried to elevate practical examples of states and facilities where they've applied these strategies and it's worked, and we've highlighted them in case examples in the toolkit. You'll find tools and tips for identifying and engaging additional stakeholders, for action planning, framing messaging, and a whole host of other tools and resources. And here are just some additional resources you have in the slide deck, which I believe if you weren't already sent a PDF copy of today's slides, you will be. And the links are in here, which I'm also sure these are the links that Samar's been dropping into the chat as well, that you have here. So I hope, I think I've left enough time for any questions, thoughts, comments. Yeah.
Tamana, thank you so much. This presentation was excellent. I think one thing I took away is that you have put in this presentation why and how we need to focus with tobacco control here in Virginia. So great presentation. Two other takeaways I got was, were that we know what works, right? We know the best practices that took down traditional general cigarette use with the general population. And we need to apply these with individuals with behavioral health conditions too. And also, people die an average of 15 to 25 years earlier because of tobacco use health conditions. So this is a focus that we really need to be working on. So Thank you so much for coming today. I'm going to turn it over to Nicole because I know she may have some questions from the box.
Hi, good morning. Thank you for that presentation, Tamana. Again, like Gina said, I really appreciated how you told us the facts, you told us why, and you told us, the next steps and what you guys offer. And Samar in the chat, you linked all the great resources, and I was like, oh, you're on it so quick. So I'm glad. And I know people in the chat have responded and really appreciate the information. So we have a few questions, and one of the first one is, sometimes with behavioral health facilities, they have so much to focus on, as you've talked about in the chat. And some people feel like tobacco is the less of the evils. So sometimes these providers feel like they don't have time or it's not the most important. So what advice do you have to those providers to prioritize tobacco cessation and prevention and integrating these policies and your recommendations that you've talked about today?
Yeah, it's so important that you bring that up too, because it's something that we see with everyone we work with across the country, right? Especially now, if not even before, behavioral health providers are just probably overwhelmed, right? Really addressing their clients' needs, their patients' needs. And I mentioned, the tobacco use often takes a backseat because as providers, we're addressing the current symptomology. How are people presenting to us in that moment, right? And that is where we feel responsibility to address first and foremost. What I would say to that is, if we were to look at just integrating treatment, right, into our practice, start with some seamless, low-hanging fruit that doesn't feel like a burden. For example, a lot of Quitlines offer the facts to quit. Oh, do people still fax? They might have upgraded since I started way back when, but they offer some really seamless transitions and referrals into the Quitline. And maybe it's during an intake or during a visit that referral is just sent off, right? And so if you don't have the capacity to provide that tobacco cessation counseling and provide that support here and there, it might be integrating a screening question on your intake form and then utilizing a quick referral to the Quitline, right? It might be, I'm not sure what the current state of Virginia facilities are right now during COVID. I know in the beginning of COVID, a lot of facilities closed down. And as some facilities were reopening, we were working with them to reopen as tobacco-free. It was an opportunity to go ahead and put some tobacco-free policies into place as they were reopening. But it's not to say that even if you have reopened or you never closed, that you can't still go tobacco-free. That might feel like a daunting task to achieve by yourself, but that is, again, where we can offer additional support, connect you to other facilities that have done it themselves, and they can offer the best guidance and insight and how to approach that. The one thing I would say to providers and working in these facilities is, don't feel like you have to do everything all at once, right? Again, pick and choose where you want to start based on your capacity and your needs at the time. I would say the Quitlines is, referring to the Quitlines is easy to integrate in. The other thing, when you're ready, we can also work with providers and facilities on how do you integrate then if you do want to take on that cessation counseling, integrating motivational interviewing into your practice to really help with that cessation counseling. There's a lot of quick 2 to 3 minute screening assessments that we can coach folks on how to adopt into their practice. It's called screening to brief intervention, or the 2 A's and R's. Probably a lot of you have heard of 5 A's, which is pretty widely used and common in tobacco control, but the Ask, Advise, Refer is the quicker version of that screening. So there, you don't feel like you have to do the most comprehensive thing all at once and apply all the strategies all at once. There are some quick takes on each of these, and it's just figuring out what might seem more seamless to all to integrate first.
Thank you. I really appreciate that. And to going off of the tobacco, the 5 A's or the AAR. So for Virginia, we've worked with our Quitline provider Optum, and we have actually created an online training, so brief tobacco intervention. And so we're working on adding some CME credits, so that'll be good, but it gives the information to the provider. And so on their time, instead of having one of the regional coordinators come out and, training the staff, we have it online. So it's easily accessible to these providers. They get a quick overview of kind of tobacco overview and background of tobacco use, and also what the Quitline does, and also how they can quickly do that brief intervention with their patients, and some resources as well. I think
That's
that
great.
training, that's really big. And I like how you talked about how you kind of pick and choose what you can do. Don't feel like you have to do everything at once. And sometimes things definitely take time, especially, integrating the tobacco-free campus policy. And I like how you had the 10 steps, I think. And someone in the comments said they like the breakdown of steps, and it kind of makes it something that looks very big, more tangible.
Yes.
You're more able to do it. So I appreciate that. And it's not so overwhelming. And as Neely said in the chat, baby steps definitely work.
Baby steps. Absolutely. And I think, Samara, I'm thinking out loud. You might have included it in the chat. I can't actually remember where it is, but we also do that. the tobacco-free facilities and the policies, we have sample policy language too. So if any provider, any facility on the call today is looking for that resource, you can always send it to, we have sample policy language that other facilities have developed. So also don't feel like you have to start from scratch, right? It's almost the benefit of engaging an entity like us that have done this work across the country with a lot of folks. We have a collective, a library of these resources. So you don't feel like you have to start from scratch. Just take what exists, what we know works, and then tailor it to best fit you.
Yeah, I think that's great. For Virginia, we also have tobacco-free policy samples too. So in addition to your resource, we can help too. I know Public Health Law Center can look over those policies. So there's a ton of resources, ton of people who want to work on this and help. So I think the more resources, the more helpful it can be. So we all kind of work together. So on another question with behavioral health organizations, I know you said, you guys providers have a lot to think about and to do. And so sometimes we hear exceptions they want for tobacco-free policies, for example, like day programs or for individuals with intellectual disabilities or with severe mental illness. Do you have any thoughts or tips? You've probably heard this in the field.
In terms of how it would apply in a policy for a facility. So the way that we have worked with other states and facilities, it's almost a all or none, right? Because you're trying to protect public health of everyone that is under your roof and your grounds, right? And this means even staff, right? And I know that a lot of facilities often feel some trepidation, like, are we going to lose clients? Are we going to lose staff, right? If we try to institute these policies. We have found that has not happened, actually. And we have some research studies we can point you all to and other facilities across the country that have looked at the same thing. And so it goes back to the equity and inclusion for all and really prioritizing the public health. So all of your clients' health at once. And how do we, especially with the environmental approaches, because you can't silo somebody out, right?
Yeah, that's a great answer. Including everyone. And I think it's the losing staff is definitely an important aspect some people think of, but someone told me that sometimes creating a tobacco-free policy in their work area makes it easier, or kind of is that push for that employee to quit because they've always thought about it. And if you create that tobacco-free policy, you're here a third of your day, even more.
Yeah.
And so if you can't use tobacco where you are most of the day, then it encourages them to quit. So I think that's a great topic.
And you're not forcing them to quit, right? It's just saying with the tobacco-free policies, hey, we're not going to smoke on these grounds, right? And so maybe, and what we've seen facilities do is offer support, NRTs or counseling or additional support for their staff members while they are on facility grounds during that time, right? So how can we best help you get through the day? Right, we're not forcing you to quit, but then to your point, yes, then what happens is that it is kind of the catalyst.
Definitely. All right, next question. You kind of covered this in the slides, but this is a great opportunity to kind of go more into the different factors. So how does tobacco cessation look different for this population? As Gina said, the behavioral health, 40% of our population, 25% of our population identifies with a behavioral health condition, but they consume 40% of the cigarettes. So how is our tobacco cessation efforts going to be different for this population?
Yeah, I mean, so it's easier for me to describe when I compare it to what happened with the general population, right? There were these mass public health interventions that were implemented to really drive down those rates of the general population. However, when we look at our particular population, so individuals with mental health, substance use challenges, And really thinking back to that slide I showed you of those disadvantages and examining risk, right? Most of our, so individuals with mental health substance use challenges are coming in with a trauma history and a lot of disadvantages that are combined or really working against them to long-term cessation, right? So that is why we never talk about tobacco control and addressing these tobacco-related disparities for this particular population without talking about all of the systems approaches, right? Yes, for facilities that are just now starting to integrate some of these strategies, I absolutely think you should start with baby steps, start with the low-hanging fruit and grow. But at the end of the day, we really can't start chipping away at the disparity that this group faces unless we are really applying that systems level approach. So addressing the environmental concerns, addressing increasing that access, increasing quality of care, all of those things. It really is going to take a combination and a concerted effort of all of those things coming together to really start to see those trend lines go down for this particular population.
I'm going to wrap it up now. I know we're coming to an end of our webinar today. Thank you again, Tamana and Samara, for joining us and really providing this information that is going to really hopefully walk us through the next few months as we start to focus on this population. So thank you so much, and all of the resources that you provided. I did want to share one thing with our Quitline, Virginia Quit Now. We do have a program for people with behavioral health conditions, and we offer, because we do have a high number of callers that self-identify with a behavioral health condition. And if you do call our Quitline and identify with a behavioral health condition, you will get up to 12 weeks of NRT for people without insurance, and also the multi-session counseling call, a 7-call session. So that's like the best practice for using cessation help. Although we are pleased to announce that in November, we will be offering these services to anyone, insurance or no insurance, that calls with a behavioral health condition. So I think with Virginia Quit Now, we're offering really the best practice for really cessation. So we're hoping to promote this to all behavioral health facilities, to all people that identify with a behavioral health condition, to call the Quitline and get those resources to provide. So please share that information. We have some flyers that we'll share with you as well. So again, as we wrap up, I did want to announce that next month, October the 19th, we will be having another Tobacco Free Tuesday webinar, and we will be talking with the Eliminate Tobacco Use group with higher education, and we will have a couple presenters from Virginia colleges and universities that will talk about how they have recently implemented tobacco-free policies on their campus. So we hope you all join us next month. We hope you invite your colleagues and anyone in your coalition groups to join us to learn more about how we can take colleges and universities tobacco-free. So much work that we can do here in Virginia, so many opportunities. I think we have heard from Tamana, one that definitely has to be our focus with tobacco control as we move from general population targeting to more targeted approach to really reach that population that has a higher prevalence use. So again, I'm going to end today. I think this is our first official day of fall, right? So enjoy today, enjoy fall, and we will hopefully see you back next month. Thank you so much, everyone.